Hello, everyone. My name is Dr. Charisse Ward. I'm an interventional cardiologist at Cardiovascular Institute of the South. I would like to thank Dr. Walker for inviting me to speak at the NCVH Digital Educational Series. I'll be discussing interventional outcomes, women versus men. I have no disclosures and no conflicts of interest. Cardiovascular disease is the #1 killer of women, claiming more lives than all cancers combined. Since 1984, more women than men have died each year from heart disease. 1 out of 31 women each year are killed by breast cancer. Cardiovascular disease kills 1 out of 3 women. That's approximately 1 woman every single minute. The cold truth is that 90% of women have 1 or more risk factors for developing heart disease. And after her first heart attack, 26% of women over the age of 45 die within a year, compared to 19% of men. And 2 out of 3 women who die of heart disease, 2 out of 3 women who die of heart disease have no previous warning signs. Directed research, increased physician awareness, and public education has helped to close the gap with regards to excess cardiovascular morbidity and mortality for women. But we clearly still have a lot more work to do. Compared to men, women undergoing primary PCI for ST elevation myocardial infarction have a higher risk of in-hospital death and risk of ischemic cardiac and cerebrovascular events. Access-related complications were also found to be twice as high in women, irrespective of the indication. There's also a disproportionately high rate of in-hospital and late mortality for women undergoing elective PCI when compared to men undergoing elective PCI. There was a recent study evaluating the differential impact of heart failure with reduced ejection fraction in men versus women. And that study showed that women with heart failure due to reduced ejection fraction live longer than men, but their quality of life is worse, with greater self-reported psychological and physical disability. In addition, this study showed that women received suboptimal treatment with the underuse of diuretics, overuse of digoxin, and underuse of device therapy compared to men. Yet women continue to be underrepresented in coronary artery disease trials, ACS trials, and heart failure trials. We know that peripheral arterial disease is quite prevalent. In fact, more than 8 million Americans over the age of 40 years old have PAD. The prevalence increases with age, and in patients over the age of 70, the prevalence can approach 20%. Historically, male gender was listed as a PAD risk factor, but more recent studies reveal that the prevalence of PAD in women is similar or may even be higher compared to men. In fact, a 2010 US Census showed that there are more women than men with PAD among US adults over the age of 40, yet the majority of subjects studied in PAD trials have been male and continue to be predominantly male. We know that women are more likely than men to be asymptomatic, more likely to present with subtle symptoms, or to have symptoms that are misdiagnosed or attributed to arthritis, gout, or part of the normal aging process. Women are more likely to be older at presentation and more likely to have impaired mobility at presentation and a much more rapid functional decline compared to men. Women are also more likely to have advanced disease at the time of intervention. And to illustrate this, I'll show you one of our patients that presented with critical limb ischemia. Unfortunately, at this point of presentation, she never had an evaluation of her vascular system. So we performed a peripheral angiogram and used pedal access. With angiosome-directed revascularization, we can see that she had significant improvement and a prevention of limb loss. So 6 weeks after revascularization and with debridement and a multidisciplinary approach, you can see the difference. And 1 year after revascularization, she had complete healing and she did not require further interventions. It's important to note that with peripheral arterial interventions, women have more complications, including more need for transfusions, more vascular access complications, and more embolic complications. Studies also show that compared with men, women show significantly higher rates of all-cause death, MI, major amputation, and major adverse limb events with endovascular treatment. Women undergoing iliac angioplasty and stenting for critical limb ischemia were found to have significantly reduced primary stent patency and a need for additional procedures to obtain limb salvage when compared to men. The risk of death after elective iliac angioplasty or stenting was also found to be significantly higher in women. In women undergoing bypass graft or stent thrombosis, a multivariate analysis identified female gender as an independent predictor of bypass graft or stent thrombosis. There is also an interaction with gender and race in predicting bypass graft, failure, and amputation, with Black women faring much worse than other groups. We know that women are less likely than men to develop an abdominal aortic aneurysm. However, those women that develop an abdominal aortic aneurysm fare much, much worse than men. The threshold of 5.5 centimeters for intervention may be too high for women, and recent data suggests that a 5.5 centimeter AAA in a man might carry a similar rupture risk to that of a 5.2 centimeter AAA in a woman. Thus, existing evidence suggests that women carry higher risk than men. Therefore, it would seem reasonable to advocate for a conservative aneurysm diameter threshold of 5 centimeters for elective intervention in women. For women undergoing EVAR, the mortality was found to be similar. However, the perioperative complications were greater for women compared to men. Women were found to be older than men at the time of repair, and women were found to have more endoleaks compared to men, but there was no difference in the rates of arterial re-interventions required for women versus men in the follow-up period. A recent propensity-matched analysis from the Medicare database in ruptured AAA repair showed that EVAR treatment simply did not appear to benefit women to the same extent than it did for men. And the long-term outcome for repair for elective AAA was also worse for women. In summary, women are dying from cardiovascular disease. There continues to be disparities in the recognition, treatment, and interventional outcomes for women with cardiovascular disease. There are many opportunities for us to increase the number of women in clinical trials and to improve the evidence base and interventional outcomes for women. Fully understanding these gender-based disparities in the treatment of cardiovascular disease, evaluating the barriers to care, and eliminating those barriers can have a transformative effect on the way care is delivered and on the lives of our patients. Thank you for your time and for your attention.